So welcome everyone to this iWiMS session of July 15. We have two great speakers from France and the US. Please make sure that if you do use the material presented in this session, you will acknowledge the speakers and the registries that those data are belonging to. And if you have some question, please use the chat box. So our next speaker is Celine Louapre from the French registry. And Celine and the French registry, as you all know, I'm sure, have published just the data in JAMA Neurology. So congratulations to you. Celine, you're going to present on NMOSD and COVID-19.
Yes, exactly. We are going to change a little bit the topic. Although I can really also update you a little bit about MS patients. So I did not update the table here compared to the one. So this is the demographic of the MS cohort that has been published at the end of the month of June. But now we have, I just did another extraction yesterday. We have 405 patients with MS and diagnosed with COVID-19. There's no different message compared to the one that was conveyed by the publication. And we looked specifically at some treatments, although in France we have a specific situation is that the anti-CD20, especially ocrelizumab, has been approved just 1 year ago for reimbursement. So the patients who were treated with anti-CD20 before that were mostly the progressive patients or very severe patients. And therefore we cannot really disentangle the problem of the neurological disability and the treatment. So I'm not sure that this is going to come from the French registry. And still we did not find any signal of more severe COVID-19 course for patients treated with ocrelizumab, but again we have it only for less than what has been used in other countries. The only signal that we have now that was not obtained before with a little less patients is that the group of patients that I named in that paper, the very low risk, including interferon and glatiramer acetate, was significantly having lower severe course compared to all the other groups of patients, untreated or treated patients. That may be driving somehow the idea that maybe interferon patients have a more favorable course, although they also may be underrepresented in that cohort. None of the patients on interferon were hospitalized in the COViMS registry. But let's move on to the NMO patients. So it's not going to be so many statistics. Actually, there won't be any statistics because we have only 15 patients with NMO and related disorders, because we have 5 patients with aquaporin-4 antibodies, 5 patients with MOG antibodies, and 5 patients who fulfill the criteria for NMOSD but negative for both for AQP4 and MOG antibodies. So the mean age of these 15 patients was 39 years old. We have 11 female, 4 male. The median EDSS was 3. Most of the patients were the ones who were tested for with a PCR swab were positive. And most of them also had, the one who had a thoracic CT scan were also positive for the thoracic CT scan. So the main outcome of the registry was COVID-19 severity score on this scale, ordinal scale, from not hospitalized up to death, 7. And the cutoff that we chose were patients over 3, which meant hospitalized, not requiring supplemental oxygen. So next I'm going to show you the details of the patients that we included in that cohort. with NMO and related disorders. So here is the cutoff of hospitalized patients. So we had 5 patients who were hospitalized and 10 patients not hospitalized. Most of them had a benign course, not even with any limitation on activities. If you want to look maybe directly on the DMT, so among the patients who were not hospitalized due to COVID-19, we have 1 patient on ofatumumab, 1 patient on azathioprine, 1 patient of mycophenolate mofetil, 1, 2, 3, 4 patients on rituximab, then again 1 on mycophenolate mofetil, azathioprine, and mycophenolate mofetil again. I'm not sure to find again where there are, but some of the patients, or maybe I did not mention it, but some of the patients had negative PCR but then a positive serology. And then let's look maybe at the patients who were hospitalized for COVID-19. So 1 patient, 36-year-old male, was already hospitalized due to a relapse, and so he got the infection while in hospitalization. All of the patients were on rituximab, among the ones who were hospitalized. So 2 of them did not need oxygen. 2 of them were in need of oxygen. The 3 here on these 3 lines were having a pneumonia, classical pneumonia linked to COVID-19. And 1 young patient had a very severe course. It was a 25-year-old female with an EDSS of 4. She had 14 years of disease duration. It was she had aquaporin 4 antibodies, and she was on rituximab. And she went on ICU from the 3rd day after she got anosmia. So she started with anosmia and then went very quickly on ICU, and then she went intubated with mechanical ventilation during 19 days. And she had really severe critical illness, polyneuromyopathy. And the only comorbidity that she has is that she had obesity. And this is quite similar with what we had also in the COViMS registry with a very severe case. Most of them also had obesity as a comorbidity. This is just a graph showing the relation between age, EDSS, the serological status of NMO patients, so aquaporin 4, MOG positive or negative for both antibodies, and the severity of the COVID-19 severity score is in this color chart, green, yellow, and red. So this is the patient we have just talked about. And so again, we are not going to make any statistic, but just to give you an overview, the patients who were not in need of hospitalization were a little bit younger than the one hospitalized, with a slightly higher, longer disease duration and a slightly lower EDSS range. So I think this is it about the patients that we could collect data with NMO or related disorders and who were diagnosed with COVID-19 in France. So.
Thank you very much, Celine.
So Celine, I think, I'm not sure we discussed that, but in the previous comments you made that the patients you had that were on anti-CD20 and were PCR positive, the serology were mostly negative when it was checked. And you meant the COVID-19 serology, right?
Yeah, the COVID-19 serology. So we looked at the serology for the one who were PCR confirmed, and most of them are negative with a serology. So
how long after, Celine? How long after? Sorry, how long after?
So we did it twice. Yes, 1 month. Well, yeah, at least 3 weeks after the infection. Yeah. But then we repeat again 1 month later. So we are almost 2 months now for most of the patients, because anyway, the outbreak started really to decrease mid-May. So we are now more than 2 months from this. And so we repeat again, those patients did did not have a
Seroconvert.
detectable. Yeah, so we are going to run a really systematic study with all patients with all different treatments, and we'll see what's going up. But this is going to be a problem because some patients were not tested at the acute phase, and so even if we don't know if having antibodies is really something that can protect for later reinfection, but still, if you don't even have the antibody, you cannot really be sure if it was not something else, if you had really mild symptoms, because we also had patients with on anti-CD20 with mild symptoms. So, but conversely, also we had, for example, a very severe patient who got pneumonia, not very severe, was classical pneumonia. He was hospitalized, and still he stayed negative. So we were about to say, okay, should we repeat or not the anti-CD20 infusion? Should we delay? We don't know. But and there were also in MS and related disorders journal, there were several case reports of patients with rituximab or ocrelizumab who did not also convert on serology. So
it's very interesting because, as you know, the sensitivity of serology, especially in the ELISA and the rapid testing, is widely variable. Many tests that are out there, so it's quite interesting.
Yeah. So we're going to centralize all the serum of those patients, and then we can test with any assay that we want. But I think we need that kind of study to really understand what's going on, and even in time. It's not only maybe at 2 or 3 months. It can be also interesting, like 6 months later, what's actually the serology, even in patients on, I don't know, other MS treatments.
Yes, it's very interesting. Asia Wallach has a comment. We have found most of our anti-CD20 patients do not seroconvert as well. Yeah, there was a comment. So thank you so much, Celine. If there's some more question, I'll come back to you later. But at this time, I will invite Amber Salter for the COViMS Registry in the US to present. Amber, yes, you there? Yes. Hi, how are you?
Hi, good, thanks. So thank you for having me speak today. I think consistent with what you've heard the other speakers say, we have more cases, but I think what we see as our results are generally consistent with what we've presented in the past. But nonetheless, I'll just show what we have so far. Or at this, as far as today. So we have 390 patients in the registry. We have a majority of them are confirmed MS or CIS, and we have about 13 NMO patients that are in the registry. The average age is close to 49, with some standard deviation around that, about 13 years of age. The majority, well, I'd say about a quarter of our participants or of our cases are Caucasian, white. We do have a fair number of African Americans reported in our registry as well. It's almost a little over 20%. And we have about 12% Hispanic or Latinos reported in with COVID-19 infections. The proportion of males and females is generally consistent with what we would expect, in 3/4 female. This is just an update of where our cases are coming from. We'll see that the bulk of them, I would say, well, at least a quarter are from New York, New Jersey, and we're still getting cases input from those areas after the fact, a little bit retrospectively. They have a lot of them to get entered, and so that's taking a little bit of time. But we can also see that we've got starting to get a rise in some of our larger states. So here, we still don't have a lot from kind of the midsection of the country, but they also don't necessarily have a lot of infections either. let's see, so 3/4 are relapsing remitting, and the majority are taking a DMT, and the majority are laboratory positive for COVID. And again, here are emergency, about 40% have visited an emergency room, about 30% are hospitalized, and then we're still seeing a low number or lower numbers that have been admitted to the ICU or ventilated, and we have 22 deaths, about 6%. And so just a little bit more demographics on the cases reported that are deceased. We're starting to see an evening out here. This may be one of the little bit of a change, is that we have about 50% of the deaths are male, and the other 50% are female. This was a little more higher skewed towards the males. And then consistent with what a lot of other people have reported in the literature, especially in MS cases, we are seeing the deceased being older. The majority of ours are Caucasian, and we have an older disease duration associated with those that are deceased. We are seeing more of the progressive population. These all are obviously pretty tied together, and a large proportion of these are non-ambulatory or walking with assistance, so equivalent to, of course, the higher end of the EDSS scale. A large proportion have a comorbidity. And let's see, so just listing, we also have not done any statistics in anything multivariate. We are, obviously there's a lot, some sparseness across some of these categories, and we have a little bit of quite a bit of ocrelizumab participants that have been reported in here. And this, the proportion of deaths out of those that are taking ocrelizumab is about almost 4% of the deaths of those within that category. And we can see that a lot of these are also coming from the deceased or have been hospitalized, as we might expect. And the comorbidities that we've seen, we have quite a few that have reported hypertension, diabetes, and cardiovascular disease, and morbid obesity. We can see that there are the comorbidity count associated with those that are deceased are it's not just one, and not a lot of smokers. I think that's it.
Thank you, Amber.
Amber, do you feel, looking at your numbers, that maybe so far there's been an over-reporting of more severe cases compared to what may have happened in reality?
I don't know as if we know that exactly. I would say that it's likely that the more severe cases have been reported. It will be interesting, obviously not a great thing, but I think to see how maybe as a younger population is now becoming infected, to see how the numbers change. And we hope that obviously that this doesn't continue, but it is going on in the US. So, we are keeping this open and hoping that people will continue to report cases as they know, and hopefully not just the severe ones, because it would be interesting to see across the spectrum as best we can.
Yeah, thank you. I don't think there's any question yet, but coming back to this mortality, excess mortality, I just noticed that Jackie Bernard was saying that, referring to this question of mortality in COVID-19 and MS, excess mortality can also represent cardiac death, CAD. And for everyone, Ellen Tremlett has posted a reference from her group in British Columbia that people with MS not attending an MS clinic have more comorbidities than people who do go to an MS clinic. So she's posted the link. Another question is from Matthias. how is COVID affecting your choosing of DMD for naive patients?
I think it's a complicated question because it depends also of the severity of the presentation of the patients. I know in my case, I felt that 2 of my patients should start on Tysabri or anti-CD20 agents because they had really a very severe disease. But as of 2 weeks ago, I have started to talk to my patients about the overrepresentation of patients on anti-CD20 agents for the risk of infection and for the risk of a severe outcome. So I think that people can help you to make that choice also if you put on the table what is known at this point. And that's why it's been really great to have these calls, because it's really every week I update my little section on COVID-19 and MS and risk because of all the information that are being shared.
Thank you, Emmanuel. So Ellen, do you want to ask your question? You have a comment there in the chat.
Yeah, I mean, for me, I think, the data that were published from Sweden in late 2019, demonstrate a strong uptick in the risk of serious infection with prolonged use of these medications. So not saying I'm super surprised that we're seeing this potential association, although I think, there's a little bit more work to be done. And, personally, of course, I'm biased because I wrote the protocol, but I'm continue to be, further entrenched in the equipoise of understanding for first treatment, whether the benefits outweigh the risks of an aggressive early treatment strategy. So, which obviously we're addressing in Treat MS and Dan and Deliver. So.
Thank you, Ellen. Thank you, Emmanuel, for answering the Matthew's question.
So Fabienne, maybe I could just add
yes, sure.
that the bulk of infections in that previous publication of ours, most of those hospital requiring patients were actually bacterial infections, whereas COVID-19 is viral. So in a way, this is still surprising, I think.
Well,
did we understand? Yeah.
Do you think that the death of the patients on the overrepresentation of death of patients on anti-CD20 could actually be related to secondary infections? We can think that it could be directly related to COVID-19, but maybe they develop nosocomial infections once they're in the hospital or in the ICU. So I think it's going to be hard to tease out what's directly related to COVID or what could be related to increased secondary bacterial infection.
So was that a question for me?
No, that it's just a comment. It's a comment, and I'm not sure our registries are.
I was a bit unclear. So we have just had 2 cases, 2 fatalities in the MS COVID cohort, and just one of them being on rituximab. So the excess mortality was just a general mortality rate of the entire registry, and we haven't attributed those 25 or 30 excess letalities in a specific ways yet. So we don't know what the reason was. But it has not been our experience that the COVID patients get many secondary bacterial infections. And in that previous paper of ours, that was indeed the bulk of the infections reported. So it is a surprise that rituximab or anti-CD20 does give an increased risk of a viral infection. I think that is biologically interesting. It doesn't really fit. I mean, it's a new observation in that respect.
I agree, and unless they were practicing less social distanciation, which I would tend to think they didn't because of my clinic when I speak to my patients on IV drugs, so whether it's natalizumab or rituximab, I feel that they are very very careful in terms of their exposures. And Jan,
Yes.
do you have any data, or will you be able to have data down the line on IV steroid use? Because you've seen in the Italian registry, they showed that recent IV or pulse steroid use was associated with much higher risk of death and ICU admission.
So done that detailed study yet, so I need to disappoint you on that.
Yeah. And Celine, do you have any data for the MOG NMOSD?
For the
do you have
MS
anyone?
Yeah, for the MS patients, we have looked at the methylprednisolone treatment, and it was not associated with more severe case. But we have maybe 15 patients who, or even less, I don't remember the exact count. For the patients on NMO, there was no, apart maybe from the patient who was on the relapse, already hospitalized, but it was in rehabilitation, and I think it was more than 30 days after the corticosteroid, because the patient had, after his relapse, he had a plasma exchange. So yeah, but in the COVID, in the MS patients, the treatments with methylprednisolone was really concerning very few patients, and I mean high dose, not because some patient, I remember one patient had asthma, and so he had corticoid for asthma, but it was not the same dose as for a relapse. We had like 1 or 2 patients who started MS just after COVID infection, but I mean, this was really anecdotic cases, not much information about that.
Yes, thank you. And Amber, you also will have some, seems that you'll have some NMOSD cases in your cohort. So maybe you'll have some information on heavy steroid treatments in the MOG antibody positive ones.
Yes, I can add that to the slide for next time.
Okay. So many interesting data. So I think if there's no more questions, which I can't see, but there's been many questions today, so it's a bit, chat is continually expanding, but I think there's no more. I just wanted to ask to thank everyone, Jan, Celine, and Amber, for the presentations. Those calls have been fantastic, and it's great that some data that were presented very early on, like the ones of Jan's and Maria Piassomani, have now come together, and it seems that there is something there. So you were right. So thank you to Celine and Amber and to Jan, and thank you to all for coming to this call. So see you in 2 weeks, I think, but we'll confirm. Thank you.
Our pleasure. Thank you so much for organizing.
Thank you.